Evening, friends. I'm Dr. Sushant Soni. I'm from AIMS Delhi and I'm the pathology faculty with Unacademy app. Is it working? Is everything fine? Are you able to hear me? Just a sec. I guess we are waiting for this to work. Just give me a sec. Is it working now? Okay, okay. So starting with the image-based discussion of pathology, here I'll be taking care of one of the toughest topics in systemic pathology, that is kidney, followed by lungs. So starting with our first image. Firstly, Bache, I'll expect all of you to just concentrate on what I am speaking. Don't worry about making notes. Everything will be given to you in the downloadable form. Images are the make and the break factor, as you very well know, and they will play an important role in NEET PG. So starting with our first image, that is kidney. As you can easily see here, it shows the presence of an enlarged kidney. It is showing an enlarged kidney with multiple cystic spaces. You are able to make out that it has a bosselated outer surface. As you can see on the slide, it has three images. The first image shows a massively enlarged kidney with a bosselated outer surface. On cut section, the cysts are distributed randomly in cortex and medulla. So this is a cystic disease of the kidney. Which one? It is adult polycystic kidney disease, that is adult PKD, versus the third image, which has a smooth outer surface with presence of cysts at right angles to the renal capsule, which is the characteristic feature of childhood PKD, which is the characteristic feature of childhood polycystic kidney disease. So let us have a quick recap. Cystic diseases of the kidney are of three main types, that is the polycystic kidney diseases, the medullary cystic diseases, the multicystic renal dysplasia, and lastly it is acquired or dialysis associated cystic disease. I'm waiting for the slide to be changed on PPT. The cystic diseases, they are of three types: polycystic kidney diseases, medullary cystic diseases, multicystic renal dysplasia, and acquired or dialysis associated. PKD is further of two types, adult and childhood. These were the images we saw. Now, if the same disease is occurring in both adults as well as children, what will be the inheritance pattern in the childhood type? It is autosomal recessive. Autosomal recessive manifests when both the alleles are abnormal. If both are abnormal, it will manifest earlier, that is in childhood. Versus adult PKD, which is autosomal dominant. Next, adult PKD is both the kidneys are enlarged as compared to normal. Which is more enlarged? Adult PKD, because adult kidney is larger than childhood, has a bosselated outer surface with cysts which are randomly distributed, versus childhood PKD, which has a smooth outer surface and the cysts are present at right angles to the medulla. This is adult versus childhood polycystic kidney disease. Next, this gets us to a next image, diagnosis. What we see here again is the presence of kidney. What we see here is the presence of kidney showing multiple cysts, which are restricted to the medulla. It shows the presence of multiple cysts. You are able to make them out here, which are restricted to the medulla. So diagnosis, medullary sponge disease. In medullary sponge disease, the cysts are restricted to the medulla. Versus having a look at the next slide, that is, it again shows an enlarged kidney. This next slide shows the presence of an enlarged kidney in which it shows the presence of cysts more commonly at the corticomedullary junction with extensive fibrosis. With extensive fibrosis. So, diagnosis, this is nephronophthisis. This is nephronophthisis. Both medullary sponge disease as well as nephronophthisis are medullary cystic diseases. Next. These were what we discussed till now were the gross images of the cystic disease of kidney. Starting with the microscopies. What you see here firstly, what is this? Light microscopy. Whenever you are having a look at light microscopy, be unbiased. First look at the structure, organ, and then the disease. So what you see here, structure, is the presence of a glomerulus. This is a glomerulus with renal tubules on the side, making the organ as kidney. Making the organ as kidney. Diagnosis. What will you say in this? Diagnosis. It shows the presence of capillaries which have a nice open patent lumen, and the capillaries, they are well spread apart, and all the capillaries, they are well spread apart in the glomerulus, making this as a nice normal microscopy of kidney. I always start with normal. This is normal. Next, differentiate this image from this one. What you see here is normal, abnormal. What you see here is again the presence of a glomerulus with renal tubules on the side. Glomerulus with renal tubules on the side, making the organ as kidney again. What you see is this is abnormal because here the capillaries are aggregated together to form lobules. The capillaries, they are aggregated together to form lobules. This is called as accentuation. This is called as accentuation of lobular architecture. That is, the capillaries, they are aggregated into lobules. The lobules have increased in size. Accentuation of lobular architecture seen in MPGN. Seen in MPGN. Membranoproliferative glomerulonephritis. This again is an important image and you need to know this. Next, having a look at this technique. What you see is immunofluorescence. This is immunofluorescence, in which this is a spotter actually. What you see here is the presence of a diffuse linear deposit. It cannot be more linear than this. Diffuse linear deposit, which is characteristic feature of Goodpasture's syndrome. Diffuse linear deposit, which is characteristic feature of Goodpasture syndrome. Goodpasture syndrome, it is associated with the presence of which antibody? It has anti-GBM antibody. Goodpasture syndrome shows the presence of anti-GBM antibody. When we'll have a look at the theory portion for kidney or the MCQs, we'll make a proper list of the sites of deposits with the diseases associated. Here, today, I'll just have a quick recap of the same, nothing major. Next, diagnosis. Again, an important slide. This is the characteristic immunofluorescence picture of MGN, membranous glomerulonephritis. I always remember it as, those of you who have seen Iron Man 3, you know that when the villain shows the brain to the girl, this is what it looks like. So I always remember it like that. Iron Man 3, remember that? Remember MGN, membranous glomerulonephritis. This was last year's November AIMS image. Nothing was written, diagnosis question mark image, MGN. Next, a common query I get in live classes is how will we recognize this as MGN? Bache, by seeing it. The more you see, the more you will remember. Next, diagnosis. I like you to tell me the diagnosis in this. I'm telling you that this is glomerular immunofluorescence. This is glomerular immunofluorescence diagnosis. Diagnosis. Acha, before I go further, friends, are you comfortable with the speed of the lecture? Firstly, and secondly, in case you have any queries whatsoever, you can simply type it in the live chat. I'll be more than happy to answer them. Firstly, what you see here is the presence of interspersed deposit. This was glomerular immunofluorescence, interspersed deposit. Which cells are present interspersed in the kidney? Mesangial cells. The cells which are present interspersed in the kidney are mesangial cells. Mesangial cells. So diagnosis: disease with a mesangial deposit, that is IgA nephropathy. That is IgA nephropathy, also called as Buerger's disease. Also called as Buerger's disease. Next, diagnosis. An extremely important slide and a good prospective question. I want you to tell me this. Dekho, have a good look at this image. What you see here is the presence of a glomerulus. What you see here is a glomerulus with renal tubules on the side, making the parent organ again as kidney. Now, what is the problem in this slide? The problem in this is, normally the glomerulus shows the presence of renal capillaries with a nice open patent lumen. Here the lumen is gone. This is called as endocapillary proliferation. This is endocapillary proliferation. Endocapillary proliferation, which is a feature of massive endocapillary proliferation, which is a feature of PSGN, post-streptococcal glomerulonephritis. Next, another pointer that you are seeing here towards PSGN is the presence of these neutrophils. Neutrophilic infiltration. All these cells that you are able to see in the kidney, all these are neutrophils. Neutrophilic infiltration with massive endocapillary proliferation is a feature of PSGN. This is an important prospective question. Have a good look. Next, diagnosis. A spotter. You very well know that this is immunofluorescence of the kidney. You are even able to have a look at the background glomerulus. This is immunofluorescence of the kidney, showing the presence of lumpy, bumpy granular deposits. The immunofluorescence deposits, they are aggregated together to form lumpy, bumpy deposits. This is not my language. This is what Robbins says classically for this disease. That is lumpy, bumpy granular deposits. Lumpy, bumpy granular deposits, giving it the classical starry sky immunofluorescence. Giving it the classical starry sky appearance on immunofluorescence seen in PSGN. Seen in PSGN. Do not confuse the starry sky appearance of PSGN with mesangial deposits. Let us have a look at mesangial deposits again. Have a look at this. Here, majority of the deposits were singly scattered. They were not lumpy bumpy, they were singly scattered. Versus PSGN, which has lumpy bumpy granular deposits. Next, diagnosis. This was November AIMS 2018 question. Nothing was given, just question mark diagnosis with 4 options. The minute I see this slide, what you see here is many immunofluorescences are given. Let it be IgG, IgA, IgM, C1q, C3, kappa, lambda. So many things are given, and we are able to see a pattern against each of these. This is called as the full house immunofluorescence. This is called as the full house effect or the full house immunofluorescence effect associated with SLE. Associated with lupus nephritis. Full house immunofluorescence associated with SLE. Next, diagnosis. Electron microscopy. Showing you, have a look at the first image. Whenever electron microscopic image will be given to you, the structure of interest will always be marked with an arrow. Now, in the first image, you have the arrow which is present on these elongated structures. That is, these are the foot processes. These are the foot processes seen in a nice normal kidney. See, this is the basement membrane. This thick structure is the basement membrane with presence of these are the foot processes of podocytes which are marked. The second slide, the arrow is again on foot processes showing diffuse effacement or loss of foot processes. The second image shows you diffuse effacement or loss of foot processes of podocytes, which is the diagnostic hallmark of MCD, that is minimal change disease. This again is an important prospective question. Next, diagnosis. What you see here, again this is electron microscopy. Now there is no arrow, nothing. But even when I have a look at this, I am able to make out that this is the point of interest. This big thing that is present is the point of interest. That is, this is humps. It looks like a camel hump. Humps seen in PSGN. I need not tell you, on electron microscopy, 3 appearances. Diffuse effacement of foot processes, which is the characteristic feature of minimal change disease, MCD. Humps, which are seen in PSGN. And spike and dome appearance, which is seen in MGN. Next, diagnosis. Parent organ. Firstly, parent organ. What you see here is kidney. How do I know this is kidney? Because of the presence of glomeruli on the side, making this as kidney. Now let us assume the right hand side image was not there. You just had the left hand side image. Diagnosis in that case would be thyroid. This looks like thyroid. So now combine the two together. In kidney, the renal tubules are looking like thyroid. That is thyroidization of renal tubules. Which is the microscopic feature of CPN, chronic pyelonephritis, CPN. Thyroidization of renal tubules, CPN. Next, diagnosis. Again a spotter. Firstly, parent organ. Be unbiased. What we have seen throughout is look at the structure followed by organ followed by disease. In none of the images that I'll be discussing with you, I'll discuss around 200 images in the regular class. Whichever image I'll discuss with you, I will not give you any options. If you prepare the harder way, it is easier when the options come in front of you. So parent organ, kidney. This shows the presence of glomerulus, in which the capillaries are pushed to one side with presence of crescent on the outside. This is the half moon or the crescentric shape which is present on the outside. So diagnosis, crescentric glomerulonephritis, also called as RPGN, rapidly progressive glomerulonephritis or crescentric glomerulonephritis. When we will have a look at the theory part, we will see the diseases associated with RPGN, the classification, the types and everything. Right now, I am just concerned with one point. the crescent that we see can be of two types. It can either be a fibrous crescent or it can be a cellular crescent. That is the crescent. It is either made up of fibers or is made up of cells. In this slide, you are even able to see the presence of the nuclei. That is, this is a cellular crescent. This is a cellular crescent. Versus, have a look at this slide. This is a very broken glomerulus showing again the presence of capillaries. These are the capillaries which are pushed to one side with presence of crescent on the outside. Capillaries pushed to one side with presence of crescent on the outside. Here the crescentric shape is made up of fibers. That is, this is a fibrous crescent. This is a fibrous crescent. Again, the diagnosis, I'll write it below. This is a fibrous crescent, making the diagnosis again as RPGN, rapidly progressive glomerulonephritis. Next, diagnosis. First, look at the parent organ. Again, you are able to see a luminal structure. This is the luminal structure in which the muscle layer is increasing in size. Hyperplastic arteriolytis, giving it the onion skin appearance. Hyperplastic arteriolytis, giving it the classical onion skin appearance, which is a feature of malignant hypertension. Onion skinning, which is a feature of malignant hypertension. Next, diagnosis. This was last year's All India question. Diagnosis. Parent organ, glomerulus. You are able to make out that this is a glomerulus, showing the presence of these nodules. That is nodular glomerulosclerosis. Associated with diabetic nephropathy. In this module, I am just showing you the images in this half an hour session. So when we'll be having the theory part of this is a rapid revision module. When we'll discuss the theory part, we'll be doing this in detail. Nodular glomerulosclerosis associated with diabetic nephropathy. Diabetic nephropathy shows two types of patterns: nodular glomerulosclerosis and diffuse. Nodular glomerulosclerosis is more specific and is associated with the presence of KW lesions. KW lesions being Kimmel-Stale-Wilson mesangial nodules or lesions. Next, so firstly, this takes care of your major images which are asked from kidney. Next, let us now go to the second topic, that is parent organ. Firstly, be unbiased. What you see here is the presence of alveoli. With air inside it. Diagnosis organ, lungs. Diagnosis, one of the most common answers I hear in live classes, emphysema. But nahi bache, this is a nice normal lung. What you see here is the normal sequelae of division. That is respiratory bronchiole, alveolar duct and sac. This is a nice normal lung. Differentiate this with one of the images with which majority of the students get confused. That is parent organ. Firstly, again this is the presence of lung. You are able to see multiple alveoli with air inside it, making this as lung, with showing the presence of massively dilated acinus. That is, this is emphysema. What is emphysema? It is irreversible dilatation distal to terminal bronchiole. Irreversible dilatation distal to terminal bronchiole, that is of the acinus, making it as emphysema. So do not confuse emphysema with a normal lung. Next, answer. The arrow mark structures are composed of. Firstly, I am telling you or let me rephrase it. The examiner has given to you this image as sputum microscopy, and he is asking you the composition of the structures marked with the arrow. You very well know that if it is sputum microscopy, these are the charcoal laden crystals which are seen in asthma. So the question is not that these are charcoal laden crystals, but what are they composed of? Charcoal laden crystals, they are composed of the protein galectin 10. Has to be remembered. Charcoal laden crystals, galectin 10. So the examiner can ask you not just the diagnosis, but a step forward, that is galectin 10. Next, diagnosis. Again, sputum microscopy showing aggregates of cells. These are columnar cells which are present together in aggregates, giving it the classical Crayola bodies, showing the presence of classical Crayola bodies. Columnar cells present in aggregates. Crayola bodies again seen in asthma. Next, most common malignancy associated with this is answer bache. Firstly, diagnosis. You are able to see, I am telling you this is lung microscopy. You are able to see the presence of these elongated fibers which are brown in color. That is, these are the asbestos fibers with hemocentrin on them. That is ferruginous bodies associated with asbestosis. So, the most common malignancy associated with asbestosis is, in my live classes in revision, normally I hear the answer as mesothelioma. Nahi bache. Most specific malignancy with asbestosis is mesothelioma, whereas the most common malignancy associated with this is lung adenocarcinoma. Do not confuse between the two. Most common lung adenocarcinoma, most specific mesothelioma. Next, diagnosis. What you see here is the presence of loose connective tissue fibers, which are the classical Mason bodies. This is an important prospective question. Have a good look at this. I'll be stressing a lot upon this when we have our theory discussion. It's Mason bodies seen in BOOP, that is bronchiolitis obliterans organizing pneumonia. BOOP, bronchiolitis obliterans organizing pneumonia, also called as cryptogenic organizing pneumonia. Next, diagnosis. Firstly, this is a giant cell. How do I know this is a giant cell? Giant cell is a cell with multiple nuclei. This is a giant cell showing the presence of a stellate or star-shaped inclusion. So, stellate or star-shaped inclusions in giant cells are called as asteroid bodies. They are called as asteroid bodies seen in sarcoidosis. Asteroid bodies seen in sarcoidosis. Next. So, in this discussion, it was just a topic in which I discussed extensively the images of the kidney and few images of lung. You can have a look at the extensive pathology image-based discussion, which will be a 5-hour discussion session. In this 5 hours module, the first 2 sessions will be of systemic pathology images, which are divided into session 1 and 2, being done on 18th and 19th December. Each session will be for 1 hour each. Day 3 will be hematology and general path images, followed by day 4 and day 5, which will be a rapid revision of MCQs of the previous year papers, previous 2 to 3 year aims as well as NEET papers, followed by prospective questions. This module should absolutely take care of any image based question that you're going to get in NEET 2020. Needless to say, bache, bestest of luck for your paper, and in case you have any queries whatsoever, you can simply put it on the Unacademy platform. Take care and good luck.